Hello, everyone. My name is David Dodick, and I want to thank the meeting organizers for the honor and the invitation to present at what looks like an outstanding meeting. I hope this is the last time I have to say I wish I could be there in person, but I truly do think this is probably the last time I will say that. I've been given the topic Rationale for Dual Therapy with Therapies Targeting CGRP Signaling. Interesting topic. By way of disclosure, this is both my relevant and full disclosure statement. Relevant to this presentation, I'll be discussing GPANs and CGRP monoclonal antibodies, and I've consulted with the manufacturers for each of the drugs that I'll be talking about. From an objective standpoint, I do want to discuss the rationale for dual therapy in general, the rationale for dual therapy with therapies directed towards CGRP, either the peptide or the receptor, and the rationale for dual therapy with CGRP and other drugs with different mechanisms of action. Now, preventive therapy for migraine is not optimal. 2/3 of people who are candidate for preventive migraine treatment don't use it, and of those who do, 70% discontinue by 6 months. Even after patients are switched to another preventive drug or reinitiated on the same drug or drugs within the same class, you can see here that after a second preventive is added, 87 to 92% discontinue, and after a third preventive is added, the numbers approach almost 100%. So even those patients who do access and are treated with preventive therapy, the overwhelming majority discontinue the medicine and discontinue subsequent preventive medicines within a year's period of time. Acute treatment is also suboptimal. In a recent study entitled the MASS study in the US, with over 15,000 patients or people with migraine in the population, 95% were identified as having at least one unmet acute treatment need, while less than 17% were actually using triptans. Most of the people in this population, almost 3/4, were using over-the-counter medications. So acute treatment is suboptimal. When I talked about the fact that most people who are started on preventive therapy discontinue medication, the question is why? Some people propose that it's because of the fact that the medication worked so well that the disease went into remission. That occurs, as you can see here, in about 1 in 10. In actual fact, the overwhelming majority discontinue preventive medications because of a lack of efficacy or because of side effects. And the two of these aren't, of course, mutually exclusive. Now, migraine is a prototypic polygenetic disease. At last count, there are 123 risk loci and subtype-specific risk alleles. In addition to that, there is an overwhelming influence on this polygenetic disease by diet, by lifestyle, by environment. And in addition, there is a plethora of targets for both acute and preventive therapies that have either been developed or are in development. So with all of this and the undoubted presence of subgroups of patients who are going to be more or less responsive to certain therapies, in the absence of predictive response biomarkers, who actually thinks that this disease is going to be optimally managed for the majority of patients with monotherapy? That's a question. I don't necessarily have the answer for that, but at least in 2022, I think based on the data I just showed you, it's the minority. Now, when one looks at the CGRP targeted therapies, and I'm showing you now broadly what was found in clinical trials, for patients with episodic migraine, about 40 to 62% respond. And by respond, as you know, that means the proportion of people who have a greater than 50% in mean monthly migraine days over a period of 3 or 6 months. For chronic migraine, it's about 28 to 55%. So it's somewhat attenuated response in those with chronic migraine. In people with episodic migraine who have been treated with GPANs for acute treatment, the range is 19 to 21%. So about 1 in 5 will have what from a regulatory standpoint is a response, which is a pain-free response within 2 hours. And for the CGRP mAbs in particular, about 1/3 discontinue them in practice in the real world based on real world evidence from a number of different countries due to either lack of effect or adverse events. So clearly in the majority, a CGRP monotherapy for prevention is not optimal in the majority, in that only about half respond, and of those that do respond, about 30% end up discontinuing in practice. Now, combining treatments for prevention is nothing new. Many experts have talked about the pros and cons of combination therapy. Yes, we seek monotherapy, and that is ideal so as to minimize the number of medicines that a patient is on. But pushing monotherapy to its highest tolerated dose does increase the risk for risk factors in this particularly sensitive population. And some have argued that perhaps combining different medicines with different mechanisms of actions at very small dosages could actually provide some synergy for the patient while minimizing the adverse events associated with any of the medicines. There, of course, have been others who have proposed that combination therapy is rational, especially in patients with treatment-resistant migraine or chronic migraine, and especially in patients who have comorbid diseases that may not be optimally managed with a single therapy. Let's take, for example, a patient who has migraine and depression that may not be optimally managed with a tricyclic antidepressant, since tricyclics are never first line or even second line these days for the optimal management of depression. So combination therapy does have a place, especially for those more severely affected and especially for those with comorbid diseases. So let's hone in then on dual therapy, which is the focus of this presentation. And let's talk about dual therapy with two therapies directed toward the CGRP pathway. And let's first talk about dual CGRP therapies for prevention. So as you probably know and have seen, there are a number of reports from different countries around the world demonstrating a possible synergy between onabotulinum toxin A and CGRP monoclonal antibodies in patients with chronic migraine. And a number of open label case series, anecdotal reports have been published in the literature, and I've illustrated some of these here. The largest and most recent of these was a paper that showed that patients were treated with 2 cycles of onabotulinum toxin A and had a reduction of about 6.4 migraine days per month, still experiencing about 14 migraine days per month, so still clearly requiring something additional for prevention. After being added to a CGRP monoclonal antibody, either a ligand or receptor targeted antibody, there was a further 4.6 migraine day reduction on average, and about a third of the patients had a greater than 50% reduction from the baseline of 14 days. So clearly, in some patients, adding a monoclonal antibody to botulinum toxin can provide at least additive effect, if not a synergistic effect. And the proposed hypothesis for why there might be synergy between these two different compounds was recently published in Headache. And the proposal is that CGRP monoclonal antibodies have been found to inhibit the activation of thinly myelinated A delta fibers, which is where the CGRP receptor is located, whereas onabotulinum toxin A, at least one of its mechanisms of actions, is to prevent the adhesion of synaptic vesicles to the cell surface membrane, thereby inhibiting the release of vesicular-contained neuropeptides, one of which, of course, is CGRP. And this predominantly occurs in unmyelinated C fibers. So within the trigeminal nerve, you have the potential for onabotulinum toxin A to inhibit CGRP release from C fibers, whereas if you have a ligand or a receptor-targeted antibody, you can either bind the peptide that is released or bind the receptor, thereby preventing CGRP from binding the receptor. And this occurs predominantly through the inhibition of activation of A delta fibers. So there perhaps is some potential for synergy there. And that is the rationale for combining onabotulinum toxin A with a CGRP monoclonal antibody. I've had plenty of experience doing this myself, especially when the antibodies were first released and they were essentially free of charge, and we could optimize the management of those people who were on botulinum toxin and responding, but still had a significant number of migraine days. And myself, and of course, many colleagues have found that combining the two is not only well tolerated, both being biologics, both not interacting with each other, but also effective in some patients. How about 2 CGRP therapies, both acute and a preventive? So in other words, adding a GPAN to a monoclonal antibody. This was a PK and a safety study looking at the combination of ubrogepant with either arenyumab or galcanezumab. So patients had a dose, single dose of ubrogepant, had PK sampling. Then 1 week later, they had the injection of either arenyumab, 140 milligrams, or galcanezumab, 240 milligrams, and ubrogepant added on top of that once daily for 4 days, and had PK sampling during each of those days. And basically what this group found was that the PK profile of ubrogepant was not significantly changed, and no safety concerns were identified when ubrogepant was co-administered with arenyumab or galcanezumab. Now, I will say 2 things about this. Number 1, it was only 40 patients. So you have to acknowledge that it was a small number of patients, and we can't really talk about safety in a large population of patients when it's based on 40 patients. Secondly, one wouldn't have expected a change in the PK profile of ubrogepant with a biologic that is metabolized in the reticuloendothelial system. They are essentially peptides that's broken down by peptidases into either amino acids or smaller peptide fragments. So one wouldn't really expect a change in PK. And the concern is not so much a drug-drug interaction between the GPANT and a monoclonal antibody, but creating what is essentially a human knockout. CGRP is important for vasodilation, and in people at risk with either hypertension or underlying cardiovascular disease, combining a GPANT and a monoclonal antibody and essentially creating a human knockout could increase the risk for serious adverse events, even in the absence of drug-drug interaction per se. Another study that was published with only 13 patients, but perhaps a little more relevant, is that these patients were taking rimegepant for up to 3 months, up to once daily, while on arenyumab, fremanezumab, or galcanezumab. And at least in this small cohort of patients who were using a GPANT more frequently over a longer period of time, there were no safety issues identified. We actually looked at this in our practice. We looked at over 100 patients when ubrogepant was first approved, and looked at how this drug was performing in clinical practice. And what we found, actually, which is not what we were looking for, but we were interested in, was whether or not patients, when they were treated with a GPANT who had been on a monoclonal antibody, had any evidence of increased safety concerns, adverse events, and what the response was. And what we found was that the response and non-response to a CGRP mAb was both a positive and negative predictor, respectively, to a good response to ubrogepant, such that patients who achieve a response with arenyumab, a greater than 50% reduction in headache frequency, were 4.5 times more likely to be a good responder to ubrogepant. And by good responder, we define that as a pain-free response or a headache response going from moderate to severe or severe to mild or none within 2 hours in 3/4 of their treated attacks. So this wasn't just single attack. These were patients who consistently responded to ubrogepant in at least 75% of their attacks. So those who actually responded to arenyumab, that was a positive predictor, a very powerful positive predictor that they would respond well to ubrogepant. On the converse, those who did not respond to a CGRP mAb, in this case arenyumab, because it was most patients were treated at that time with arenyumab. So those patients who had less than a 30% decrease in frequency and were considered non-responders, those patients were unlikely to have a good response to ubrogepant. So it actually seemed just the opposite of what was predicted before these drugs actually appeared. We questioned what would happen adding ubrogepant or a GPANT to someone on a mAb, and whether there would be acute treatment efficacy when the pathway was already blocked. Many predicted that GPANTs wouldn't be effective. In actual fact, it turns out that they're probably more effective in people who are both on a mAb and responding to a mAb. Same thing, by the way, parenthetically, was found for onabotulinum toxin A. Patients who were responding to onabotulinum toxin A were more likely to have a good response to ubrogepant, and patients not responding to onabotulinum toxin A were unlikely to have a good response to ubrogepant. So both onabotulinum toxin A and the monoclonal antibody was a positive predictor of response in those who were responding to those preventives. This was recent data that was presented at the American Headache Society meeting last year from what they refer to as the COURAGE study. This is a study looking at data coming out of the Migraine Buddy app. 430 patients or people were analyzed in the population with migraine. Those patients who took one dose of ubrogepant, that was 352 patients, 193 of whom were on a monoclonal antibody, and 102 were on onabotulinum toxin A, and 57 were on both onabotulinum toxin A and a monoclonal antibody. But this data focuses in on just those who had taken ubrogepant and were on a monoclonal antibody. And you can see that in terms of a 2-hour and 4-hour meaningful pain relief, and that was just loosely defined as patients who felt that ubrogepant was providing meaningful pain relief in 2 hours, 64%, and almost 85% at 4 hours had meaningful pain relief. These are patients on ubrogepant and a monoclonal antibody. Now that's definitely higher than what we saw in clinical trials, and it's a rather robust response to a gepant. Again, supporting the preliminary evidence from our group that using a gepant in patients who are on and responding to a monoclonal antibody is more likely to have a positive response to the gepant than those who aren't responding to a monoclonal antibody. This was an analysis that I thought I would show because it looked at predictors of response to erenumab in a cohort of patients with migraine, and the only predictor of response to erenumab was the response to a triptan. Now, triptans, of course, also block the release of CGRP in addition to other neuropeptides. So it's, again, we're seeing that patients who respond to blockade of the CGRP pathway perhaps are more likely to respond to acute drugs that block the CGRP pathway, either by preventing its release or by blocking the receptor. And maybe the converse is true, where those patients who have an acute treatment response to, in this case, a triptan, but also perhaps a gepant, may have a more positive response to a CGRP monoclonal antibody. So why a single CGRP signaling pathway drug may not be the single solution for most patients? So on the left-hand side, the question is why CGRP signaling therapy alone may not be sufficient in general. We know that 3/4 or less of people with migraine can be reproducibly and reliably triggered by CGRP infusion, so there must be other factors at play in those patients. Only about 50% of people who are treated with a CGRP monoclonal antibody, or indeed a gepant for prevention, have a response, a greater than 50% reduction in mean monthly migraine days, and less than 10% have a complete response. Now, we have all had a couple of patients in our practice who, after their first dose of a monoclonal antibody, never have another migraine attack. But those are exceptions, and they're exceptionally rare, but they do occur. But for the overwhelming majority of people, they continue to have attacks. gepants and certainly the monoclonal antibodies are thought to have a peripherally restricted site of action predominantly, and there may be patients who require more centrally acting drugs based on the particular mechanisms and pathophysiology in that particular patient. And then again, there are other, in fact, many neuropeptides and or inflammatory cytokines that may predominate in certain patients and in certain subgroups of patients, so that targeting one of these peptides may not be the single answer or a sufficient answer for many patients. Then there's the question is why dual CGRP signaling therapy may be required. So why would there be a need to add a gepant to a monoclonal antibody? Well, we know that CGRP receptor monoclonal antibodies and antagonists only block CGRP action at the canonical receptor, by and large. And we know that CGRP binds with equal affinity to the amylin 1 receptor. And recently, we've seen from studies from Misudashina's group, that signaling from both amylin and adrenomedullin can, like CGRP, trigger migraine attacks in predisposed individuals. So it's possible that by blocking the canonical receptor, one leaves the amylin 1 receptor unbound, and CGRP can signal through that receptor and perhaps result in nociception and a migraine and trigger a migraine attack. It also may be a safety valve, if you will, so that acting through the amylin 1 receptor provides that compensatory potential dilation, vasodilation that's necessary in some patients. Perhaps a little known fact is that CGRP, when it's released, is released in bolus-like fashion with a volume transmission. So there are 10,000 CGRP peptides per dense core vesicle. So when the trigeminal C fiber depolarizes and has a quantal release of CGRP, the system may be overwhelmed, and that whatever CGRP peptide monoclonal antibody is present, not all of the CGRP is bound, and there's plenty of CGRP that is available to act through its receptor. So that's one fact, and that perhaps adding a CGRP receptor antagonist to those on a CGRP ligand monoclonal antibody may provide additional support that's required when those trigeminal neurons fire. In addition to that, when CGRP binds its receptor, or even a CGRP receptor antagonist binds the receptor, and it's internalized, there's endosomal signaling within the cytoplasm of the cell, and that endosomal signaling, when that's blocked, can be when it's blocked, there's an anti-nociceptive effect by blocking that endosomal signaling. So there's a variety of reasons why adding a CGRP therapy to a patient who's already on a CGRP therapy may be effective. And we've certainly seen this in clinical practice. We've certainly seen, as I mentioned, where adding a GPANT to a patient on a monoclonal antibody, actually the efficacy is enhanced, maybe because of more potent blockade of the CGRP pathway. And another particular area where I found GPANTs to be effective is in those patients that have a wearing off effect before the next dose of their monoclonal antibody. And we've certainly seen in our practice and in a study we published from our group that up to a third of patients will have a wearing off effect in the days to week before the next injection. And we found that actually treating those patients with a GPANT on those days can provide relief of that wearing off effect. Now, there's no evidence for that. That's just anecdotal, and but it's something we found in clinical practice. So there does appear to be a role of combining a GPANT with a monoclonal antibody. What we don't know is the safety and efficacy of actually using a GPANT prophylactically in someone who's on an antibody and responding, but with a suboptimal or partial response. I'm not sure that there's going to be any studies. I don't know what the safety of doing that is. We've not done that ourselves in clinical practice, or at least I have not. But maybe that study will be done if indeed we can demonstrate that that's safe. How about CGRP pathway inhibitors and non-CGRP therapies? Well, I put this up only to speculate that perhaps the reason why, with all of the real-world evidence that's coming forward from multiple different countries in highly treatment-refractory patient populations, in our series, for example, they failed on average 11 different preventive medications. So these are not patients that were generally seen in the clinical trials. These are very treatment-refractory patients with almost all with chronic migraine and who had failed multiple preventive therapies and who had a high level of comorbid diseases. And yet, we were seeing response rates of 42 to 74%, depending on what study you looked at. And the question is why? Why were these drugs performing so well in practice in this treatment refractory group? It could be that many of these patients in these real-world evidence studies had significantly refractive chronic migraine and were on preventive medication, non-CGRP preventive medication, at the time where CGRP monoclonal antibody was initiated. Certainly in our group, when a patient is on an oral preventive drug, they are not discontinued before starting the monoclonal antibody, because of course they may be experiencing a partial response to that therapy, and there would be no need to discontinue it when starting an antibody because of the potential for significant withdrawal and rebound or recurrent or severe withdrawal headaches. And also because the CGRP monoclonal antibodies are biologic, there should be no drug-drug interaction. So the overwhelming majority of our patients, they simply had the antibody added on. And it could be that adding a CGRP monoclonal antibody to an oral preventive therapy that has a completely different mechanism of action may provide an additive effect as well, sort of like we saw with the onabotulinum toxin A monoclonal antibody combination. So this remains to be seen, and I look forward to the results of this PEARL study, which is a very large real-world study of fremanezumab effectiveness in patients with chronic and episodic migraine across multiple sites in Europe. And it's this kind of sort of rigorous real-world evidence study conducted over a long period of time that's going to answer those questions as to whether adding a monoclonal antibody to an oral therapy that has a completely different mechanism of action has some synergistic effect. So when to consider dual therapy? I think CGRP monoclonal antibodies lend themselves to the addition of other preventive or acute medications because of that lack of drug-drug interactions. I think one would consider dual therapy in patients with chronic migraine or high-frequency episodic migraine, especially when there's a high level of disability, when there's a partial response to a prior or current preventive medication, and when there's a comorbid disease that needs to be managed with a different medication, such as depression, or another condition that needs to be managed with another medicine, such as obesity or insomnia. And then combining the G-PANT with a monoclonal antibody, I think, is rational when there's a history or a patient has risk for medication overuse headache, because we've seen preclinically that ubrogepant at least does not have the propensity to cause medication overuse headache. And of course, we've seen now with rimegepant and atogepant that giving those G-PANTs every other day, or indeed daily, even up to twice a day, has a preventive effect rather than producing medication overuse headache. Whereas every other acute treatment has a propensity to cause medication overuse headache. As I said, perhaps in those patients who have wearing off prior to the next monthly injection of their monoclonal antibody, that may be an opportunity to use a G-PANT for intermittent prophylaxis, if you will. And then, of course, for those patients who have a contraindication, an adverse event profile, or a non-response to triptan in the past, that may be a patient in whom you'd combine a G-PANT to a patient already on a monoclonal antibody. So these are interesting times that we're in with new therapies. These undoubtedly, all of the unanswered questions will not be answered in randomized, placebo-controlled clinical trials. It's going to take all of us reporting our clinical experience, trying to rigorously and prospectively analyze that clinical experience, and prospective longitudinal cohort real-world evidence studies like the PEARL study to be able to answer some of these questions that are critically important for patients and clinicians, where we won't get the answers from a randomized controlled clinical trial. So thank you again very much for your attention. Thank you for the invitation. Look forward to being in Copenhagen very soon, and look forward to being there at least virtually to respond to some of your questions. Thank you.